Good afternoon, everyone. I know it's been a long day, and this is a health conference, so I think what we'll do is let's just have everybody stand on their feet and follow me and just do a few stretches. If we're talking health, the National Health Dialogue, I would like to keep my audience healthy as well. So please let's stand up. It's been long and you've just had tea. I can't have anybody falling asleep on me. Thank you so much, sir. So now if I see anybody or hear any snoring, I know where to look. Good afternoon again, ladies and gentlemen, and thank you so much for your attention today. And thank you also for your presence. This is a very important conversation, and I'm going to call up my guest. I think we might need an extra chair up here, just to be sure that we fit everybody on the, on this podium. So, first off, joining me, we have the Executive Secretary for the Kwara State PHCD, Professor Nusirat Elelu. Please, a round of applause. Let's keep the applause going, please. Then we also have the Editor-in-Chief, African Journal of Health Economics, Professor Obinna Onwujekwe. Please, a round of applause for him as he makes his way to the stage. We also have the Health Editor for Premium Times, Nike Adebowale. Please, a round of applause for her. Hold on, please. All right, today the first two guests are joining us virtually. Nika just joined me on stage. Then we also have Dr. Ibrahim. We also have Dr. Ibrahim Wada, the CEO of Nisa Premier Hospital. Please, a round of applause for him. And rounding out those panelists who are on the stage with me, we have Professor Bello Jamal. He's the Executive Secretary, Kaduna State Primary Health Care Ward. Please, a round of applause for him as he comes to the stage. So just before we get started, I want to ask a question of the audience. How many people here in the last 1 year have either visited a primary health care center or know someone who has? Just show by your hands. You visited a primary health care center or you know someone who has? That is a very small number of hands in this audience. And I think it's something we need to take note of because primary health care centers are meant to be the very first line of medical defense. So let me also ask one other question. Who would choose a PHC near them as their first point of call for a non-life-threatening situation? By a show of hands, who would choose a PHC around them if it was a non-life-threatening situation? Raise your hands. Again, a very small number. And I think it's one of the things that it shows us is the lack of trust that exists for many people when it comes to primary healthcare centers. So just an establishment of the conversation we're going to have, and we will have an opportunity to take questions from the audience today. So this critical discussion is one that is on the real cost of primary healthcare in Nigeria. And our focus today is on understanding the current state of primary healthcare service delivery at the sub-national level. And as we all know, primary healthcare is the backbone of any effective health system. Yet across Nigeria, there are persistent challenges in ensuring that services are accessible, reliable, and affordable. So let's examine what it takes to deliver quality care, from funding and staffing to infrastructure and operational efficiency. So once again, thank you to my panelists here, and also thank you to the panelists joining us online. So I'm going to go first to the Executive Secretary of the Kwara State's PHCDA, Dr. Elelu, who's joining us virtually. Let's look at subnationals, and of course we know they're the closest ones to the communities. From your experience, what governance reforms are most urgent to strengthen PHC delivery at the states and LGA levels? I do hope that Dr. Elelu is online with us. Okay.
Sorry,
Hopefully, we'll be able to get her back to join the conversation. But I'll have that question also go to Professor Jama as well. So, looking at the subnationals and looking at service delivery, particularly for PHCs at that level, what are the governance reforms that you think are most urgent in order for us to strengthen our PHC delivery at the states and LGA levels?
Okay. Thank you so much. Good afternoon. No doubt there are a number of key areas that are critical, that are required to deliver quality primary health care service delivery in the country, from infrastructure of the facilities, to human resources for health, to supplies of commodities and equipment. But having asked of the most urgent, I think I would say, as a reflex, that it is human resources for health. Human resources for health, I think that is the most urgent. The staff workforce are intelligent. Whatever renovation one would have made in the PHCs, whatever equipment would have been supplied, it is the workforce, human, that would operate them. And I think we are seriously lacking in that area. So most urgently, I think, is human resources for health. Now, what has been done in Kaduna State as a prototype subnational in human resources for health is the first identification of the gap analysis and needs assessment have been conducted over the last 2 years. And from what is on ground in terms of the number, we had only 5,000 staff to man 1,136 PHCs. And this is against the 15,000 plus that has been prescribed by the minimum service package. So that's a gap of more than 10. So we had requested to His Excellency to approve the enrollment of 1,000 staff annually to fill that gap. But that would take 10 years. 10 years, if one is successful. Annual recruitment of 1,000 staff would take 10 years. And that's more than the 2-year period that an administration would have. So what we had as a correction was to have an approval to recruit 1,800 for the next 4 years, and that has been done. And 1st December 2020, next week, virtually, they will all would have been at their various stations of service. And it's not only to recruit them, to also have prompt replacement of the existing staff due to statutory retirement or death or whatever reason. So this has been there. It's not only to have them in number, but it's also to distribute them equitably. You could have some PHCs having perhaps 8, 9, 10 midwives, and another is having 0 or 1, struggling. So there's no that equity in distribution. So still under that umbrella of human resources or health address, we have to distribute them equitably. And then to train and retrain them, both in the technical aspect, the requisite knowledge they require to deliver the services, and also on moral grounds. Absenteeism, truancy, late coming, how to talk to patients and patient relatives. We have already this bad reputation as public hospitals or facilities to speak harshly to patients and patient relatives. I think somebody has mentioned that this morning.
Yes.
So we also address, because we have found out that that is an important deterrent to people coming to public space. They would rather go to traditional alternatives where they are being treated with dignity. Okay, so it's a large spectrum under human resources for health to have them in the right number, to have them the right distribution, to also have them trained in some
basically giving healthcare workers customer service training.
That's right, yes.
Basically it.
And all these things will have to be tracked, and that is been done. So in summary, I think human resources for health is what we seriously lack and like at the same time. So if it's something to be done urgently, I think it's in the same line, and some of the states have heard of. Katsina State is also doing that.
Yes.
But so this is what is should be done, I think, at subnational levels. Thank you.
Thank you so much. And I'll bring Professor Elelu back in because it's still the same question. And just to, again, domesticate this conversation, I like the fact that we've heard a lot of data and numbers today, but we also need to realize that behind those numbers are families, are mothers, daughters, sisters, wives, families that are broken apart and are suffering loss because of the failure of our public healthcare system, particularly at the primary level. So according to recent data, over 16,000 doctors and over 75,000 nurses and midwives have left Nigeria in the past several years. So you have states basically trying to fight for the number of healthcare workers that are left and trying to urge associations or councils like the Medical and Dental Council of Nigeria to, in a way, fast track the graduation of those who are available. And we're still running into issues with that. Professor Lelu, let me ask you about what's happening in Kwara State in terms of the urgent reforms. We've heard about infrastructure being an urgent reform as well as human resources. What's the Kwara story in terms of what you think needs to be done to strengthen the PHCs?
Thank you very much. Sorry, I had a poor network earlier, but I think it's better now. I hope you can hear me.
Yes, we can.
Thank you so much. Yeah. So just like my colleague has said, pretty much infrastructure, human resource for health are very critical ingredients when we talk about the first point of health system in the country, the way the health system is steered. And it's really say people to raise their hands. Although I'm not in the room, but we don't have that many hands, coming up in terms of patronage of our PHC. But having said that, for Kwara State, we are doing a whole lot in terms of infrastructure revitalization in the country. Kwara State also keys into that model. We know that the infrastructure, I always tell people that, I always have this application, come and set up a primary health care center in my village, in my settlements. Every day I have these applications coming in from community settlements and villages. And I said, look, the easiest is actually setting up the PHC infrastructure. The most difficult is actually the human resource for health. What's the building without the people that are actually going to provide those services in the states? And so for us, in the state, we're prioritizing the existing primary healthcare centers that we have and ensuring that we bring at least one functional primary healthcare center to a level 2 within all of our 193, apex wards in the state. For Kwara State, we have, 16 local governments and 193 wards. And as we speak, we have a functional primary healthcare within those facilities that we have moved onto level 2 PHC to ensure that we have a full complement of services where we are. We know that, primary healthcare centers should be available within 5-kilometer radius of a settlement, but unfortunately, this is not usually the case. So I always say, look, we can start in a strategic way. We are having one functional one, and then we can now double those numbers and in time. And that alludes to what the Honorable Coordination Minister was saying earlier, that we are going to move additional PHCs under the BACPF to ensure that, we have more functional facility, because we have some, in terms of equity, we have some wards that are even larger than some, and some that you might not need more than one facility in those wards. So in terms of human resource for health for Kwara State, we did a needs gap assessment. We did a baseline to see what are the existing human resource for health. The JAPA syndrome is a national issue. It's not a Kwara issue. Several states are battling with human resource for health. At the end of this baseline assessment that we did, we actually had a recruitment plan for the next 4 years. And every year, we are going to be recruiting over 1,000 people. And I'm glad that for this year, the governor approved last year, October, for us to recruit 1,005 health workers into our civil service in the states. And for now, we already have those 1,005 within the civil service into the primary healthcare space in the state. That has improved the quality and quantity of the people that we have. But of course, the problem still persists. We still have people in terms of equitable distribution of staff. People naturally do not want to go to, hard to reach settlements, security compromise settlements. So we are now trying to look at having situation whereby we're having performance for results, encouraging people to run shifts, whereby we have additional, funding provided as incentive for our health workers to also run those 3 shifts. That is usually a challenge in hard to reach settlements in the state. Okay. Finally, we also do a lot of capacity building, training and retraining of our health workers to ensure that, look, you are in term with some people have graduated over the last 10, 20 years and have not gone through so many new training. So what we do is to do a lot of capacity building in terms of basic emergencies, life-saving skills, and etc., to ensure that we have quality service delivery in our system. Thank you.
Thank you very much for that. And so we've heard from Kaduna and Kwara that there is a staffing issue, there is allocation issues, and then there's also, of course, training issues. And I want to come to Professor Onwojekwe now. We know that many public primary healthcare centers exist on paper or are only non-functional. And that documentary that we saw earlier was, I think for many people, it was very, very hard-hitting, the state of many primary healthcare centers across the country. What does the current evidence reveal about the real financial cost of weak public healthcare systems for Nigerian households? All right, we're having some technical issues with him, and I hope that we'll be able to connect with him very shortly. But I'll go to Dr. Ibrahim Wada, and we've seen a lot of people shifting their attention from public facilities to private facilities. And some would say there are situations in which those who are meant to be working in the public facilities direct traffic, direct patients to even their private companies or businesses. And so there's an increasing role for the private sector to play in healthcare delivery in Nigeria. So how can public-private collaboration help improve the qualities of the quality of the PHC and even the continuity of care?
Thank you. First, I must appreciate the CJID, Premium Times, the Nigeria Health Watch for this, I think, mind-blowing effort to get accounting officers from the states and the federal government here and devoting your time to address one of the most critical issues of our time. Critical in the sense that nothing about health indices favors Nigeria. However, the reason I'm here to talk is not to complain, but to tell you that our cup is half full instead of half empty. In other words, there is some hope on the horizon. You're looking for solutions. You're also looking for practical evidence. 70% or so of our nationals, our citizens, when they wake up and there's a problem with them, apart from paying out of pocket that we say, they are also being treated in private centers of different grades. So private medical practice, which was nearly zero at the time I became a doctor in 1980, is 70%. And you worry, oh, public hospitals should be the ideal. Why? Because it's cheaper, and, etc. Whether or not the statistics is clear, what is happening, especially in urban centers, is private healthcare is growing and getting bigger, innovative at the same time. I have tasted public-private partnership. What does that mean? A public hospital, the Garki Hospital, that was run publicly for like 20 years. It was the first hospital in the FCT. And after 20 years, they really had to close it because nothing was working well. They tried to renovate it, but it was very challenging. So they offered it as an experimental PPP. A government hospital, big size, more than 100 beds, had really ruled the FCDA health scenario for a long time, grounded. We were lucky in a way that we were selected. I gave a talk recently in a very transparent manner and challenged, turn this, you know, not so nice general hospital to a model, standard secondary and tertiary facility. History has shown us that in terms of facility maintenance, in terms of doctoring, in terms of results, this is far above what I had experienced in a public sector, totally public sector run place. So NISA Premier had shown the country that a public hospital can be well run by Nigerians. I did not bring foreigners to help. It's 18 years since we've been running that hospital now. Instead of being downtrodden, for example, like some of the facilities we saw, and some of the existing public general hospitals, Garki became a beautiful bride to the extent there was an effort to push us out, I think 2 years or so ago, before this new administration saw the benefit. So it's a progressive center where people who are sick, to me, if you are sick, the environment you should be treated should be as good as Hilton Hotel. It should not. Thank you. That is your time of need. And do you people know, some people don't go back home from there. That's their last port of call on earth. What business do we have to take them to dilapidated places? Is that how we want them to say bye-bye to this world? Some of them? So PPP at the general hospital level has succeeded. I am almost certain that we Nigerians as a people, like the minister was telling us, we must hold our destiny in our hands in a way that we contribute to a better healthcare. You from the media will be saying the cup is half full, not half empty. Then can this be descended to the primary healthcare level? That should be the question on anyone's mind. You want my answer?
Wait, Dr. Wada, no, Dr. Wada, hold the answer, because I'm actually coming to that question, and I think it should be part of the solutions we talk about before we wrap this conversation. Just hold on to that.
Thanks. Okay, thank you.
Thank you so much. Nike, let me bring you in. We saw what the Punch presented to us in terms of the trigger stories and then the consequences of that, how public attention and public outcry can come to bear on certain situations. And investigative journalism has revealed major gaps, deficiencies in our primary healthcare structure in terms of infrastructure, staffing, service delivery. Where is the media? How can the media continue to expose these weaknesses while also protecting sources? Because sometimes the information comes from whistleblowers. It comes from people who want to remain anonymous, who have the information from behind the scenes, and then make sure that we continue to shine a spotlight on this healthcare situation.
Okay. Thank you so much for that question. Okay. Is it okay? Okay, as health journalist, I will be speaking from my own experience. As health journalists, we're meant to actually work on stories, work on reports that actually exposes systemic gaps in primary health care. I mean, primary health care is like the bedrock of any strong healthcare system in any country. Oh, sorry, can you hear me? Okay.
They want to see your audio.
Okay, so PHC is the bedrock of any strong health system in the country, and at premium times, we know that, and that's been the core of our own reporting. So for journalists or for media to actually protect their sources while also getting their stories out, I think it's almost impossible, I must say, because we watched the documentary here and we saw faces of people that have been affected and still being affected by the poor healthcare system, especially in the rural communities. If you had not seen those faces on the screen, if we had just narrated, maybe like audio and all of that, you feel the impact, but not as much as you'd feel when you saw the video. I mean, everybody here watched the documentary and you just felt this kind of pity, like there are actually people going through this. I mean, we're seated here, like Vivian said earlier, in a space fully air-conditioned and all of that, talking about health. But you really need to go to the rural communities to see those that are really affected by this. People are really going through a lot. Like some of the investigative reports that Premium Times has done, you see people that lost their lives, their kids, like then your pregnancy halfway. There are some people with postpartum hemorrhage, just a lot of stuff that you won't see happening. I mean, well, yeah, sometimes we go to the health facility or the hospital and maybe there's just a little queue. We'll be complaining that, okay, the queue is too long and all of that. But if you go to the rural communities, they will wish that they actually have a PHC to visit and just a little queue for them. They do not even have a PHC to visit. Like, is it possible for people in rural communities to just stay and sleep well without the fear that if something happens, which health center would I be visiting? So for media and for journalists, for us to actually bridge this gap and keep reporting while also protecting our sources, what we can do is grant them anonymity. And this is what we do in Premium Times, and majority of the news outlets in Nigeria actually, they protect their sources. But again, that is kind of tricky because there are some of these sources, they'll tell you that I do not want to be anonymous. Put my face out there. What do you do in that kind of situation? I'm not sure, but I'll get back to that later. So we just grant them anonymity. In some of the stories Premium Times have published, please, you see that we mention names of some persons, but would reiterate that some of these persons don't want their name to be mentioned. Especially when it comes to health workers, you're really scared of speaking with journalists because you're scared that after the report comes out, they may lose their jobs. You know how it is in Nigeria and all of that, so they're scared of speaking with journalists. So in cases like that, we just like, okay, just give us information we need to know, and we'll just say a particular health worker in a particular place. There's a story that we also did on tuberculosis recently. I think I actually did that story. When it comes to taking pictures of the sources and all of that, we use their back sometimes or the side of their face just to protect them and let them know that, see, you're safe. We just need to put this information out there. I mean, we're working together. We're trying to get better healthcare for everyone. That's what we're doing. But again, if we're trying to take the sources out and all of that, we can actually rely on documents. There are some really strong documents in Nigeria, like the NDHS reports. It comes out, I think, every 4 or 5 years that we can actually rely on, but it is not enough. Again, we can use pictures as evidence to back this story. Again, referring to my document, to the documentary that we watched earlier, you see that some of these PHCs, we just showed you pictures to see the dilapidated state that they are in, and the pictures tells a lot of story. So instead of, if you say that your source is kind of like at risk, if you put their faces out there or put their names out there and all of that, you can actually rely on the pictures. Go to the field, get these pictures, get these videos, and tell your stories, just like in a documentary format or in a write-up format. Then I noticed that in your question, you only asked of the safety of sources. You didn't actually talk about journalists, because we actually need this safe too. You know what has been happening. I can't really say much about that, but journalist safety also matters. So at Premium Times, what we do is, if you're going to the field to work on a particular story, and either we sense it as a dangerous trip or not, you must let the office know that you're going on this trip. And yes, you need to check in. You must let the office know that you're going on this trip. So if we don't hear from you within 12 or 24 hours, we know what to do. And so like, where's Nike? Where's this person? We're not hearing from her. And she went to Akwa Ibom to work on this story. We'll be able to know what to do at a particular time and all of that. So I think apart from sources, journalist safety also matters. Then I also think to protect journalists, aside what we do at Premium Times, it's important to kind of like build maybe a cross-newsroom coalition, if I must say, like a collaboration. I always say collaboration is always more impactful over competition. If we can come together and work on a particular investigative piece, it will be more impactful, and it will also save your reporter from any risk attached to that particular report. I'll give example of the Panama Papers. Sorry, I'm taking long. I'll give example of the Panama Papers. I'm sure some persons here might know about it. A group of journalists or group of media houses actually came together to work on some leaked documents. That was like a few years ago, I think under the International Consortium of Investigative Journalists. I think Premium Times is the only Nigerian newspaper amongst those people actually. So they came together to work on very impactful investigative reports. There are some heads of country and all of that actually resigned after that particular report. So where am I heading to with that is that if those documents, because the kind of people that the document reviewed some secrets they do not want people to know about. They're really powerful people. So for instance, if I had written that story alone as Nikki Adebowale, I'm at risk. They will find me because it was really that terrible. They will look for me anywhere. But with that story, some of the bylines, you see stuff like Premium Times. You see stuff like Panama Papers. So let's assume we did the story, Premium Times, Washington DC, AP News, The Punch, Nigeria Health Watch, NAN, and all of that. We did all of the stories together. So if you want to pick a particular person, you're targeting a particular journalist. So are you going to target the entire Premium Times or the entire NAN or the organizations that came together to actually do that kind of report? No. So I'm saying that it's better for newsroom to actually collaborate, to also as a way of protecting their journalists, because I believe that a shared risk is low risk, or I say a shared risk is no risk at all, or reduced risks. Yeah.
Thank you so much.
Question?
Yes.
Thank you.
So I want to go back to Professor Jamal, and let's also continue the look on the primary healthcare centers, but also political priorities. We are a very political country, and Nigerians understand what I mean by that. It feels like oftentimes decisions are not made necessarily in the best interest of the people, but in the best interest of political. I'm looking for a word here. Of political situations, let's just leave it at that. And so when it comes to primary healthcare centers, it feels like those decisions are then life and death for the average Nigerian. And I want to know how states or how people in positions of authority like yourselves in this kind of situation can balance political priorities with the technical needs to ensure consistent funding and long-term planning for PHC systems. Nigerians want to believe that government is a continuum, whether at the federal level, the state level, or the local government level. But oftentimes it seems once an election comes, priorities change, goals change. Somehow the finish line gets moved because it's another person in place. How do we continue the momentum that seems some states are now sustaining?
Thank you so much. So I think this is an important question. When I came in as this is personal now, as the ES, I thought, and in political dispensation, I thought 90% of the job would be technical, purely, only 10% will be political. But as the days rolled by, one came to understand that actually the political component of it is actually more than 10%. So there had to be some rearrangement. But overall, as a state, I think the way to make the balance, the safest way, is to look at them distinct. This is purely political, this is technical, recognizing only the point where the two intersect. And that point of intersection is not less important than either the standalone political or the standalone technical. But I think if there is this plan initially to say, okay, this is purely political aspect, but this is the technical aspect, I think one is safe just to address the intersection. What does that mean? The sustainability now of the PHC systems. And the reality is that we have tight physical space. The foreign donation is dwindling. So the government, I think, to have this sustainability now, I think it's a complex question. I'm looking at the sustainability aspect now. It is to look at a way of sustainable funding, and two, to make this planning realistic, looking at the reality, and then to prioritize. Prioritize what activities should be there. And then to use the data that are original, not to go somewhere abstract, maybe some random website, and then imbibe their submission and apply it locally. What we have done in the state, in Kaduna State, for example, have you realized the tightness of the physical space? We were deliberate, looked at only those areas that are looking at us sternly in the face. And we came with an agenda, we call it 2+2 agenda. 2 major goals and 2 minor goals. The 2 major, number 1 is to have a reduction in maternal mortality. This is a national thing. Okay, it's not just only to say reduction in in maternal mortality. We went to put in some figures to that. Whatever you put some numbers becomes more beautiful. So we had some assumptions and comparisons with other states in the nation and then with other African countries with similar demographics and GDP as Nigeria. So we now said we want to have a 25% reduction in maternal mortality over the first 2 years of this government, 25%, and another 20% reduction over the subsequent 2 years. This is for maternal mortality. It's for childhood mortality, and by childhood we meant the infant mortality, the neonatal mortality, the under 5 mortality combined, to have a 30% reduction over the first 2 years and a 25% reduction on the residual burden, having removed the first 30% over the subsequent 2 years. So for maternal mortality, 25%, 20%. For childhood, 30, 25%. If I'm to oversimplify, for example, we say, okay, maternal mortality 800 per 100,000 per year. So you want to reduce it down to 600 realistically. So from 800 to 600, you have 200. Over 800, the emission, that's a quarter now. So that's how we got the 25%. It's oversimplification, for example. So these are the two majors. The two minors want to have an enhancement in female reproductive health, including family planning, because an average woman in Kaduna State has a fertility rate, profits here, 5.8%. I think that's massive, 5.8%. So for the most important strategy here is to reduce the birth rate. That's a simple strategy to address the maternal mortality. So first minor, enhancement of female reproductive health, including family planning, and we felt is going to help us achieve the first major. And the second minor is to have increased penetration or acceptance of vaccines in the community, because predominantly the childhood killer diseases are vaccine preventable. Sadly, we have lots of local government areas and communities as 0 dose. So we want to enhance that acceptance of vaccine that will eventually reduce the childhood mortality, which we believe is going to help us attain the second minor. So this is an initiative that is realistic, that has been prioritized, and we're looking at that 29th May this year, marked the end of the first 2 years.
So, I apologize for interrupting you, because my brain is just asking how. Mm-hmm. Because it's one thing to set the goals, it's one thing to set the timelines, but you need to answer the how. Unfortunately, we don't have time. We've shortened this session because it has been quite a day for everybody, but they have told me that I have room for 3 questions. Okay, they're saying 2. It's not my decision. We have time for 2 questions. So the first 2 hands that I see go up for anyone on the panel on this side. I've closed out. Let's start at the back, please. Okay, sorry. Please, you've asked a question. I apologize. Let me have somebody who has not asked a question so we can make sure it's gone around. Have you asked? Okay, you've spoken today. She has not. But you spoke earlier, right? Okay. So I'll start here, and then the gentleman in the back, please. Can we get... I said the first 2 I saw. Unfortunately, my direction was in my eyesight was in this direction. I apologize. Please point at him. Oh, he's the one. Please, let's start with her. Go to the gentleman in the back, and I'll beg you for 1. The lady who was standing, 1. Thank you. Please, very quickly.
Yeah, thank you so very much, Prof. I would like to start with you. I would like to know how many facilities are under Basic Healthcare Provision Fund in Kaduna State. That's 1. Now, I was going to ask a question earlier. We all know what maternal health is, and we all know how it's dealing with all of us, and we're all involved. Now, one reason that women die from maternal death is postpartum hemorrhage. I would like to know how far Kaduna State has gone in terms of the E-motive, so that we'll know if you have like a dedicated fund for E-motive to buy the commodities, and what type of commodities are you making use of? And for Dr. Wada, thank you very much. What are you advocating for Nigerians to have, let's say in the 6 geopolitical zones, to have PPP, just what we have with Garki hospitals? Do you think, I don't know, we just wanted to share your opinions on that. Thank you.
Thank you. Let's take all the questions together. The gentleman in the back, please, with his hand up.
Good afternoon.
Good afternoon.
I'm Maxwell Emmanuel. I'm an NYC delegate, a legal practitioner.
Can you speak up a little bit, please?
Yeah, Maxwell Emmanuel, an NYC delegate, and also a legal practitioner. So I would just like to take this conversation towards the drivers of PHC delivery, especially in rural areas, because I noticed we've talked a lot about infrastructure, but then a major driver we've not talking about is security. So I would love us to address the area of security, because if you observe, the places where we have most of the health centers, in order to get the target audience, are mostly in the rural communities. And most times, government invests a lot in these communities. You have solar panels, batteries, and refrigerating systems in order to store our cold chain vaccines and all. And you now realize that they leave most of these things unsupervised. No security personnel, and those parts of the communities are areas that are often overlooked. So these things are majorly there just for the taking. Anybody can walk in and vandalize. So, and also the workers there, because I'm speaking from experience, I have a sister that is in the community health service. So the place I saw her last, I was like, I didn't agree. I was like, no, you can't be here. But then she said, oh, it's my passion. I'm like, okay, if it's what you want. But then you just have to be aware that all the men in the family are so far away. So if you have an emergency, you have to rely on the security you can get around there. So I want us to talk on, while we're having conversations like this, we have to touch on security and, yeah, infrastructure.
Thank you so much. I hope Professor Elilu is online. She did mention security, but we can get her to expand. And the lady who stood up, final question so we can wrap up the session.
Thank you. Hello, everyone. Good afternoon. My name is Osas. So my question is around the issue of GBV and health disparities and how there are issues that are intersected and they disproportionately affect women, girls, and other marginalized groups. And then we know, despite Nigeria's commitments to national and international commitments to universal health coverage, but then we still see that the efforts that have been put in still don't use results. So my question will be around what innovative strategies do you think the government can take at sub-national levels to improve primary healthcare centers across Nigeria to address issues that specifically affect women, girls, and other marginalized groups? Thank you.
Is that directed at anyone here? Anyone? All right, thank you. Prof. Jama, I think we'll start with you. The question that came from the front here in terms of post-hemorrhage, advocating for PPP, and there was a third question. Did you catch all her questions?
Yes, the first was around the number of facilities that are basic healthcare. We have 255 wards in Kaduna State and 255 Apex facilities. All of them are basic healthcare provision fund facilities, and there is another 35 that are not part of the 255s, but they are also basic healthcare. We have concept of PHC centers of excellence. So in total, we have 290 in the state. Then I agree, the most important cause of mortality, maternal mortality, is obstetric hemorrhages, and postpartum hemorrhage is one of them. So we have trained 10 nurses/midwives from each of the 23 local governments that we have. So that's 230 on postpartum, not just postpartum hemorrhage, active management of third stage of labor, and specifically postpartum hemorrhage. Emotive is handy, and Professor Hadiza Galadenchi is the one that's helping us with support from Gates Foundation. So this is an important strategy we're having, and then it's over the course of 18 months from early this year. So it's a program that will be ongoing. I think that those are the two questions.
Thank you very much. Professor Elilu is still on. She had mentioned security in her first contribution to this panel, so I'd like to get in touch with her again. A specific question around not just security of the personnel, but also security of vaccines, equipment in these particular rural areas as well. Please speak to that.
Thank you very much for those questions and for in terms of before I talk about security, just to add to what my colleague said, we need to also understand that for every level of care, there is a limit, and that is why we have the referral system of care. From a primary to a secondary, care system. So when we talk about postpartum hemorrhages, we in the primary healthcare space, we also understand that we've done some trainings. We also know the limits to those care that we can provide at that level and at what stage to refer to a secondary care, especially when we have emergencies of obstetric emergencies, a complicated obstetric emergency. So that's been said. Sorry, call is coming in. So that being said, in terms of security, we have categorization of, in primary healthcare, we categorize the whole state, in the country. We have, at the state level, we have inaccessible settlement, we have partially accessible settlements, we have fully accessible settlements. So we have categorization of the PHCs, settlements, community, villages for security. And that classification or categorization will determine the kind of security approach that we provide in a PHC in that community. So for those that have some layers of insecurity, so the type of activity, for example, if it's an immunization activity, we oftentimes involve military support, vigilante support, to ensure that our health workers are protected first, even before they go into those insecure communities, which is not going to be a whole lot of places in the state. So that would depend on the type of situation that we find ourselves. But for the daily running of our PHCs, we know that the president of the country is the chief security officer of the country, and at the state level, we have the governor. So for what we do in Kwara State is to hold the local government chairman also responsible to the security within the local governments. And what we have done is to ensure that for all our Apex facilities that have been equipped with full complements of level 2 equipment, services, human health, we must provide security to those facilities. So we have the night guard, the day guards, whereby for those Apex facilities, because if there is one of the criteria for running a 24-hour service is a guard, is to have a night guard, the security. So if there is no night guard, we can't have a 24-hour service. So as one of the criteria, if of a level 2, you see that we're not having a perimeter fencing for ease of securing a perimeter. We also have a guard house at the gate where a security officer can stay. And then, of course, we also have a boys' quarters or a staff quarters for our health workers that they can provide, 24-hour service in a secure way, in that area. So basically, that is what we do in terms of security. Okay. Depends on need is what we deploy. Thank you.
All right, thank you very much. The last question is not forgotten, but because of time, Professor Jamal, I'm going to extract a promise from you that she will get an answer to her question about the GBV and health disparities and innovative ways in which government can deal with that within the primary healthcare structure. But that will have to be probably one-on-one. I've been told to wrap the session, but I think it's also a very important question in light of the fact that we're in the 16 days of activism. So thank you very much for your attention. Thank you also for your time. This is how we wrap up this session. Please, a round of applause for my panelists, as well as Professor Elelu, who joined us online. Thank you very much.